it's fabulous today to be joined by Adam Carson, who's Managing Director of South Warwickshire University Foundation Trust. So, Adam, I know you've been doing fantastic work where you are on helping people get out of hospital more quickly and have got a number of initiatives up there. So it'd be great to hear from you exactly all that you're doing.
Wonderful, thanks, and good to join you today. I was going to start by talking about some of the work that we've been doing on the Home First agenda and some of the service changes we've made over the last year to support that. So one of the things we recognise is that hospital isn't always the best environment for people. Actually, people tend to get better quicker when they are at or nearer to home, and that helps them recover. It's the best place for them to be, but also it aids flow in our hospital, and it allows us to see more people more quickly, which we know in an era of growing demand on the NHS is really important. So a couple of the initiatives I just wanted to talk about. I'll touch on our frailty service first of all. Some of the things you really don't want to see is older people, frail elderly people coming into hospital if they don't really need it, because we know for elderly people in hospital beds, they very quickly lose mobility, and it takes them a lot longer to recover and get out of hospital. So we've done some work with West Midlands Ambulance Service and set up a frailty service which sits between our acute hospital and our community services, and really helps in triaging very rapidly some of those elderly patients who call an ambulance, and allows our community services to intervene rather than them come into hospital, wait in ED, be admitted to a bed. And that triage has been working really effectively and has provided that kind of subacute level of intervention before they get into hospital to support them in a much more proactive way. And we won a parliamentary award for this initiative last year, which was fantastic, and I think really recognises the hard work of the teams. It's also a bit of a new way of thinking. I think we're in a lucky position of providing acute and community services. So it's allowed us to look at that model of care differently, and provide something that would perhaps traditionally sit between organisational boundaries. So great work there.
And as you rightly say, because you're both a community service provider and an acute provider, it makes it much more simple. It's slightly harder if you're dealing with another trust, i.e. a community trust. But your point about diverting people away from getting into hospital is so important. And of course, frailty is not just about age, is it? I mean, you've got lots of 90-year-olds who are not frail and plenty of 65-year-olds who are frail. So it's based on the frailty of the individual, not a chronological age.
Absolutely. It's about identifying that person's needs before they're conveyed by the ambulance service into hospital, and we've established a call before convey system. So some of those, when they identify those needs in a patient that's called 999, they can get straight through to our frailty team, and our frailty team can provide an assessment there and then before they come into hospital. So yeah, great stuff there.
And presumably it relies to some extent with you liaising with local authorities if additional care is needed.
Absolutely. And we've had a fantastic pilot actually with our local authority, Warwickshire County Council, over the last year to establish a community recovery service. So this is sort of at the other end of the pathway, the back door of the hospital rather than the front door of the hospital. So one thing we recognise, I think it particularly affects those frail elderly patients, but actually there are a wider group of people who are stuck in the hospital because they have care needs that mean they can't be immediately discharged to their home. And sometimes that will be equipment they need, sometimes it will be physiotherapy or therapy needs generally. And sometimes it will be that they need a step down placement, a domiciliary care provider. So this innovative service with the council, we call it the Community Recovery Service, provides a joint team or a joint service that aims to review patients that are medically ready to discharge within 24 hours of the decision to discharge them, and provide rapidly in their home some of the, or in a domiciliary care provider, some of these needs, be it physio needs or other therapy needs, very rapidly, very quickly, immediately provide that link to commissioning of the domiciliary care service and a bed in a domiciliary care service within those first few days, and is a much more joined up way of working. And we believe that has really assisted us over the last year to get people out of hospital into their own homes or into appropriate placements with a joint intervention between social care services and NHS services. That means they're getting what they need more quickly and are out of a hospital bed in a more appropriate environment where they can recover more quickly.
And that joint working between health and social care, that gap between the two has always been the difficult challenge, to close that gap, if you like. And it sounds like you really have done that now.
Absolutely. And not without a lot of effort, I have to say, and not without some fantastic individuals in the organisations that have made that happen. So one of the things we wanted to do really early was establish a joint position with the local authority. So we jointly appointed a chief commissioning officer, who's a director of commissioning for the council, who have a 50-50 job split between us and the local authority. And I think sometimes these kind of joint roles can be a bit tokenistic, but actually we got the right person in the right job with the right objectives, and they've really driven forward this agenda, and they are able to unblock some of those governance decision-making hurdles that we perhaps traditionally see in those joint working arrangements.
And I think that is key. Two bodies contributing to the salary of one person makes all the difference. I've seen it elsewhere with recruitment of staff, for instance, FE colleges and trusts appointing a joint person for to give people work experience and that sort of thing. But that is what makes the thing flow properly. So they've got dual responsibility, dual accountability, and their job is to drive it through, which is fantastic. As you say, it's probably taken a lot of effort from a lot of staff. Do you feel now it's up and running, that this will last the passage of time?
I think so. We were lucky that it was initially funded with national money, integration front runner money, and that pump primed the investment. It really got things working. We have some work to do, and I mean, almost 12 months in, are really in the phase now of proving the benefits of this service. We certainly know that they're there in terms of rapid discharge from hospital and getting people into the appropriate environment more quickly. We've seen that through a reduction in our delayed discharges, but there's a financial case to make as well, and we believe that financial case is there. But ultimately, in an NHS that's pressed for money, we need to make this a sustainable service, and that's about how we work with social care and NHS services to prove that the investment we're making is beneficial.
It demonstrates the value of pump priming initiatives like this.
Absolutely.
In terms of getting people out of hospital, it must be harder if you're taking people out of your area. So if they fall under the remit of a different county council.
Yes, absolutely. So we have been particularly pressured in the increase in emergency activity that we've seen at Warwick Hospital's emergency department in the last couple of years. And in part, that's been driven by a really significant increase in out of area activity, and to some extent, there's something about being a victim of your own success here. So all trusts are pressured. We're pressured, but we've been quite good historically at managing our emergency activity. So in some respects, we're the point of least resistance, and we're receiving intelligent conveyancing or conveyancing from other areas. And of course, we're happy to help out. That's what we should be doing in an NHS if we've got capacity to deliver where others don't. But it does mean that when we've got out of area patients in our bed, and there was a point last week, for example, where almost a third of our beds were occupied with patients out of area, they're more difficult to charge. We don't have the links with social services in other areas. Sometimes they're out of our ICB area, and that creates another hurdle and challenge. And I think what we need to look at is ensuring that all organisations have the same capacity, productivity to deliver, and that we're able to consume our own smoke. So helping out in times of pressure is important, but that shouldn't be a routine. It shouldn't be that one organisation is seen as the place to go at all times. And I think we really need to drive that agenda to ensure all trusts are able to consume their own smoke.
Absolutely, and I think that, as you say, you're a victim of your own success, but it becomes a pull factor. So you're an easy target, and then all the fantastic work you've done on frailty and Home First can't be enacted because you don't have those links with those social services departments in other county council areas. You say you're now in the position of having to make the case, which is important. You've got this successful scheme, and there are two ways the NHS looks at these things. One is, has it been good for your patients? Without a doubt. We've known for decades that taking older people, frail, elderly people into hospital is not a good idea, and they deteriorate rapidly. So you've got that. But in terms of A&E, it must have had an impact on A&E as well, and there must be financial implications that you can also cite in support of this service that you're offering.
Absolutely, yeah. So flow is critical, and flow is difficult in the NHS we're in at the moment to make a financial case for, because as soon as there's an empty bed, you fill it with someone else. So there's some real digging into the details there to make sure what we're doing and what we're proving is right. But certainly there has been a productivity benefit through the work we're doing, and productivity is going to be the big word this year, because we know it's decreased across the NHS in recent years. And also there's something about an impact on staff and making sure our staff are coping and able to deal with the demand. And actually, this service is one example of a more rewarding way for our staff to work. They are able to see people in a different way. They're able to have a cohort of patients that's more appropriate for their skills.
Yes, and so it's interesting you sort of mention your staff morale, because presumably your figures will now show that the age profile of people attending A&E, certainly from your area, has gone down. So if you matched the age profile to postcodes, it would demonstrate that your frail elderly are being diverted and not coming through the front doors of A&E. But it must also be encouraging for A&E staff. I know who, doctors and nurses, everybody working in A&E gets frustrated when they see frail elderly people coming into A&E when they didn't need to be there. If they could have been diverted, got the community support, it wouldn't have happened.
Absolutely. Nobody wants to be in a hospital bed if they don't need to be in a hospital bed, if there's a more appropriate place for them to go. And our staff and our clinicians are no different. They rather people be cared for in the most appropriate environment. Yeah. It's certainly been beneficial to them.
And I suppose it would be remiss of me, Adam, not to ask you about workforce challenges, because I think that is something facing all health and social care providers at the moment. How's it going?
Absolutely. So if you ask anyone in the NHS what the two big challenges, they'll say money and workforce. And so as a result, we set ourselves we call it a big move, a strategic objective last year we call it be a very flexible employer. because we recognise that it is harder to get staff, particularly after the pandemic. Expectations are different, and you look at younger people coming up through the workforce, and sadly I'm not one of those younger people anymore, but their expectations are different. Their expectations from an employer, what they want, what drives them, what motivates them is different. So as an organisation, we've set ourselves a goal to understand that and make sure we're reacting to the needs of our staff. So some of that is about flexible working arrangements, ensuring we've got, for example, flexible rotas, self-bookable rotas where people can choose the shifts they want to work, and it takes a bit of bravery to do things like that. But also it's looking at career pathways, giving people different opportunities, make sure we're using apprenticeship schemes, for example, developing people young, developing skills or giving exposure to different professions, providing opportunities for research. We're part of a group of trusts, so there are opportunities across our group for people to develop different skills. And it's working. So in the staff survey results that were announced a couple of weeks ago, our staff had rated us in the top 5 for best acute trusts to work at in the country. So really good news story there. Certainly more we want to do, other things we can do, but being that flexible employer that understands the needs of our staff and makes sure we're really attracting the best and retaining the best workforce is something I hope is really in our DNA.
Yeah, well, it's great to hear, and flexibility, with childcare arrangements at the younger end. Responsibility for aging parents means people don't necessarily want to work a 5-day week. It's simple as that, and accommodating that, because often staff will have different requests and different needs, which can hopefully fit together in the jigsaw, which means you have the full-time staff. Well, Adam, I have to say you've had a parliamentary award for your work. You're up in those top 5 on your staff survey. You're obviously doing a fantastic job. So I think I'll finish with saying well done to you, and well done to all the staff. Some I know who will be quite junior, who've made this possible.
Thank you. Thank you very much, Anne.
Many thanks. Okay.